Tragically, I lost my son, Ben, to a fentanyl overdose. It was the hardest thing I had ever had to endure. It's happening across Canada. Fentanyl is wiping out an entire generation of our people. So we started a foundation, Guardians of Recovery, to help people with mental health and addictions who are struggling and not included in society. We've done a great job of including people with disabilities in our society. Now imagine a world where people with mental health and addictions have that same level of inclusion. That's what we're about to do. We are inviting you to take part in one of the most progressive and creative initiatives of our time, building sober living homes for our people to make sure they are cared for and have an opportunity to completely come off substance and live normal, productive lives. Well, welcome back, everyone, to Guardians of Recovery podcast, where we dissect the intricacies of addiction, medicine, and policy, shedding light on pivotal issues shaping the landscape of recovery. I'm your host, Tina Olivero, and today we embark on a critical examination of safer supply programs in Canada with esteemed addiction medicine expert, Dr. Sharon Koivu. Welcome, Sharon.
Thank you very much for having me. It's a pleasure.
So happy to have you here, and your experience is so extensive. We truly are fortunate to have your wisdom with us today. I was hoping that we could start off with you sharing your journey with addiction as a doctor, your initial stance on safe supply, and how that sort of changed over the years. But before we even get into that, how about defining for our viewers what safe supply is and how it's impacting the country?
That's actually even a somewhat challenging question, but in general, safe supply, I don't like that term. I'll start with that. It's not safe. All opioids are toxic. That's how we got into the opioid crisis in the first place, was by prescribing a toxic drug, and opioids are toxic. Safe supply is the giving of a toxic substance to people in amounts that aren't witnessed, in large amounts. The thought is that this is instead of other, that they wouldn't be taking other drugs such as fentanyl. And the kind of argument is that a pill, you know exactly what's in it. But when you inject it, you don't know exactly how much you're going to get and what it's going to do to you. It's designed to be taken orally. So when you inject it, you can get infections that aren't part of being safe. When you're prescribed huge amounts, like I see, you aren't able to know how much is safe for you because nobody is actually witnessing you take it and determining what's safe. We also know that pills can be manufactured. Fake pills can be out there very quickly. So having a pill isn't safe. And what started me on this journey, in a way, was we thought OxyContin was safe. Then we thought hydromorph cotton, and I'll talk more about that, was safe. And then we decided that Dilaudid was safe. So they're not safe. But it's really about giving pills out in large amounts. The thought is that it's going to somehow, that the messaging is that it's about fentanyl, about an alternative to fentanyl. But fentanyl is continuing to grow. The amount of fentanyl isn't being touched by the amount of opioids, other opioids we're adding to the street. If anything, it's growing. So the thought that this is an answer to the fentanyl crisis is such a misrepresentation of what's happening. The fentanyl crisis is continuing. Fentanyl is going up. Deaths from fentanyl are continuing to rise and rise and rise. And I'll talk more about that in my own community. Having more opioids doesn't touch that. So it might be, and in theory, allowing some people a different drug, but it's not going to address how many people are going to die from fentanyl at all. And although there's some suggestion of benefit, I would like to talk about how I think the harm so far outweighs the benefit for a few. The harm to many outweighs that benefit. And it certainly outweighs that benefit within a community.
Yeah, I find the whole terms and harm reduction, everything, I actually personally find it to be manipulative, because here we have 42,000 people who have died from overdose. The number one cause of death in our youth right now is illicit drugs. It was like, oh, we're going to take this hydromorphone and, you know, all these other drugs and make fentanyl the phantom, but then make all of these drugs good and okay. And the perception out there is like we're actually doing something good, but what we're doing is taking bad medications and bad solutions and adding them to other bad solutions, making things worse, which is why the numbers are rising the way they are, as you say. So it's like the term safe supply is manipulative, and it isn't safe. And that's on the government. The fact that the government is tackling that, like harm reduction, safe supply, these terms, I think, you know, down the road, that's going to be looked at as such a wrongful marketing, I guess, problem, much like they did with Purdue. And they came out and said, you know, how OxyContin was safe and all these things. Yeah, well, they're doing the same thing with the word safe supply. I couldn't agree more. So can we sort of dive into the, I guess, key flaws that you saw in the safer supply programs? Well, first of all, we haven't heard a lot about your background as a doctor and addiction. Can you give us a little snippet as to how you got into the addictions area and I guess your journey with so-called safe supply, and then how things turned around, and you said the dangers far outweigh the solutions.
Thank you. I'll try to be succinct. Just to, oops, I'm going to, when I I've been in medicine now for 39 years. I started in family practice, and I've also been an acting medical officer of health for 10 years.
Okay.
I developed a focused practice actually first in palliative care medicine. It's an area that I have absolutely loved working in. But while I was working as a palliative care physician, I started getting consults for patients who were dying from a heart valve infection called endocarditis, so an infective heart valve infection. Right. And at that time, we knew it was a link with injecting drugs, but we didn't know what drug and what was really happening in our own community. So I shifted my focus from palliative care to addiction medicine because I was seeing a real void. We didn't have any addiction service in the hospital that I worked in, which is a tertiary care hospital in a large urban center. And as I shifted my focus, I started really concentrating on people with this infection and asking them what they were doing and what they were injecting, and was able to find out that they were injecting a capsule called hydromorphcontin, which is hydromorphone in a long-acting form. Now, as a little aside, the people that told me this first weren't the ones who were prescribed it. They were the ones who were getting it diverted. The ones that were prescribed didn't disclose at first because they were afraid of losing their prescription. Right. So they maintained a different narrative, a different story for a long time, making it harder to figure out. But over time, we were able to really even work with those people. Another physician I worked with was able to find a link with the same capsule, hydromorphone, with HIV in our community. And we actually, the health unit, finally, so between 2012 when I noticed it and 2016, our health unit declared a public health emergency for HIV and tricuspid valve endocarditis related to injecting hydromorphcontin. As part of the response, when we finally were able to get community support, when we first brought this information to the community agencies, they weren't supportive and actually were critical and even called us fearmongers. So I've been there and wasn't expecting it to happen again, but was there that time because there was a thought that HIV wasn't being spread among people who inject drugs. And the link was concerning for people who had a different thought of what was happening. But we were able to show it, and we were able to get community support. And part of that support included looking at a very high risk group, which was our street level sex workers. So they were often unfortunately, using their bodies for drugs or money. And in that, they were both spreading HIV, as well as they were dying from HIV and endocarditis. So they were our highest risk group that we really wanted to target. We just developed a group called Street Level Workers at Risk, which I was part of, which was about trying to help. One of the main initiatives was a housing first initiative for these people. Another initiative was from Intercommunity Health, which was about giving the women, or primarily women, but sex workers, hydromorphone in a pill form, which we now refer to regularly as Dilaudid. It's the same drug as they were already taking. So instead of giving them hydromorphone capsules, which some were getting prescribed and some were getting on the street, they were given hydromorphone pills as a thought that it would decrease their risk of developing the endocarditis and the HIV. And to be quite honest, that was actually research work that I was involved in that showed that the pill for those things was safer than the capsule. Okay. But I think it's really, really important to recognize we didn't have a problem with fentanyl in London at that time. Our rates of overdose death were the same as the province, and our rates of fentanyl deaths were low. Our problem, our public health emergency, was a heart valve infection and HIV from the capsules. So that's why when we started giving out the pills, I supported it. And we did have a decrease in HIV. We were able to get rid of the public health emergency in HIV and endocarditis. But after time, I started seeing problems. We started giving out more and more and more. And I guess the first thing I started seeing was, perhaps as a physician, I started seeing other infections. Particularly the one that I found disturbing was a spine infection. One of the early patients I saw who was able to tell me quite bluntly he was getting his supply of Dilaudid from people in this, which we now refer to as a safe supply program. He was living in an apartment and injecting with clean needles, and he developed a spine infection. The year after the program, I saw 5 people in 1 month, and the numbers continued to rise. So that was the first thing that made me quite worried, that we had switched one problem, like whack-a-mole. We got rid of one problem, but we created another. And to be honest, the suffering from spine infections is probably about the worst I've ever seen, because it's the most painful, and it can lead to paraplegia and quadriplegia.
Wow.
One of the other things that I want to mention is that we don't track infections. When we talk about the harms from opioids, it's just toxicity, and toxicity death is what we track, because that's accidental. Coroners track that. We're not good about tracking even deaths from infections that are related to injection drug use. And certainly we're not good at tracking suffering, what we refer to as morbidity. Those aren't tracked. And so the suffering I see basically isn't tracked. So I started seeing more suffering. I also had moved to the area near where the Safer Supply program had started the year before. It's a very core urban area, and I had moved there because I really wanted to not be NIMBY. I wanted to be able to be in the core, and I knew that that was a potential site for a supervised injection site, which I at the time was supporting and wanted to be able to be there, living in the neighborhood and supporting things that were happening in the neighborhood. But it also meant I was at ground zero as I saw things change in the neighborhood. The first thing I started seeing was that in my work, I had a patient who actually told me in June of 2018 that he had left an apartment that he lived in to live in a tent behind a pharmacy where a large amount of the diversion was taking place. Because if you were right there, especially at 8 o'clock in the morning, so the earlier you were there, and that's actually even before the pharmacy opens, which is interesting, but if you were there early, the drugs were cheaper and more abundant near the source. So close to that pharmacy, they were cheaper. Even as you got out of that neighborhood, they got a bit more expensive. And what I watched both from patients and from living there, we never had encampments there. I watched the encampment behind that pharmacy grow and grow. And it's a horrible place. It's a parking lot. And there's a stretch of parking lots. There's no sanitation. There was no water. People left homes and other places where they might have been homeless, which were safer, where there were near water or near access to toilets. So they left areas. So homelessness is an issue, but they were leaving their homes and leaving other places where they had tents to live in encampments behind this pharmacy to buy the drugs.
Right.
I also lived in the neighborhood and saw, long story short, but it changed completely. It went from being a lovely neighborhood that I absolutely adored living in to one that I actually finally left in 2021.
Yeah, and that's happening across. Yeah, it's happening across the country where these safe supply sites are. Just people don't want to have their businesses there. People don't want to have, their children growing up there. It's dangerous. There's gun shootouts. People are dying. And, if you give people personal liberties, which we have, and we've been so proud of, but you give personal liberties to people who don't have brain capacity and don't have responsibility, that's chaos and will most often lead to death. So we've set up and architected the society in such a way that no matter what, people with addiction are failing because there's no roads to recovery. Everything is in the pursuit of that drug because it's so lethal and deadly and so highly, highly addictive. I mean, people will steal machines and drive through pharmacy windows in order to get it. That's how badly and desperately it's needed at that level of addiction. We've never seen anything as strong as these drugs, and what they're doing is decimating people's minds. And underneath the privacy law and underneath our current system, we are acting as if these people actually have normal brain function and capacity, and we're allowing them back out on the streets. We're not admitting them to hospitals. So all kinds of issues. And I mean, the result speaks for itself. Work back from the results. The numbers show clearly that we don't have a handle on this.
I absolutely agree with you. And I think often we dilute the numbers and don't focus on where there has been a safe supply program. And what I want to mention is London. So the first thing, going back to London, it wasn't about fentanyl. So any benefit that is listed there is work that came out of intercommunity health, out of the program, saying that it's beneficial. But I think it's really, really important to recognize that it was a different reason that it was being used. Being on fentanyl wasn't a requirement. Many of the people were actually prescribed hydromorphone, the tablets before they started in the study, or the capsules. So it was a response to the same drug. So from a neurochemical perspective, we weren't trying to change from a strong drug to a weaker one. It was the same drug.
Right.
But what we found, exactly as you're saying, was that the more that was out there, then people started taking more. And your brain readapts. It starts needing more. And to be normal, you have to have the same amount. To get a euphoria high, you have to have more. And every time it starts wearing off, you get withdrawal. And withdrawal is horrific. It's painful. It causes severe anxiety. It can cause nausea, vomiting, and diarrhea. And people can literally feel like they're dying. So they're chasing that and will do anything to prevent it, including things that they never thought that they would do, even to their own family. So the types of things that happen when people are fighting that withdrawal, and the program of a safer supply program is about always fighting that withdrawal. It doesn't change your neurochemistry. If anything, it's increasing, allowing your brain to adapt. So what we saw here in London was after we had this program in place, we started seeing fentanyl come. Now, was it just because of the program? Probably not. There was more fentanyl everywhere else. But what we did see was that people who had access to the drugs were selling or trading them to get fentanyl. And that the fentanyl in our town has absolutely escalated, and the deaths. And the other thing I see that's really important is that as these dilaudid pills have become cheaper and cheaper and cheaper, they're much more available. We know from all our addiction work, whether it's tobacco or alcohol, the more available and the cheaper it is, the more people use it. So we're seeing more and more people starting. When I started in 2012, most people that I saw who had addiction started with a prescription from a physician, which is part of why I got involved in the first place. I was so horrified that we had done it. And then later, now most of the people I see actually start recreationally with the pills. And then as that's not good enough, they move up to fentanyl. So yes, there are definitely more deaths from fentanyl, but the entrance way, I hate using the term gateway because it's so cliche, but it is starting with pills that people think are safe. They're told it's safe by the government. I had a patient recently that actually stopped using fentanyl and crystal meth and started using Dilaudid by injection because he thought it was safe. And now he has a spine infection. So it's not necessarily a safe replacement for even what we're saying that it's safe for, but the numbers have escalated. And London locally, so in 2016, we had the same rate of death per 100,000 as the rest of Ontario. We did not have a fentanyl crisis in London. Now, in all of Ontario, the rate of death has gone up. It's gone up almost 3 times from opioids. So this isn't sepsis or other infections, this is opioids. In London, Ontario, it's gone up almost 4 times. So significantly more than the rest of Ontario. But the other area, because I keep saying I'm seeing it in young people, and people in the program will say, no, I'm not. If you look at the rates of death from toxicity in 2 groups, the 15 to 24 and the 25 to 44, if you look in those groups, in 2016, the London rates were less than the provincial average in both of those areas. Now, they're significantly more than the provincial average. So when you can actually look where there's the most effect, instead of saying, well, all of Ontario or all of BC, when you can really look where the impact is, we can see young people are getting started that weren't on opioids when we recognized the Purdue crisis. I'm seeing so many more people, so much younger people, and so many more tragedies than what I refer to as the Purdue-driven opioid crisis. And when we can narrow it down and understand it, the harm is horrific.
It is. It's huge. I mean, it's more popular to do Dilaudid right now than it is to smoke cigarettes.
It's easier.
Yeah,
it's cheaper. And if we talk about, if you're using a Dilaudid, if you're smoking tobacco or cannabis, your parents can tell. If you're drinking, if you have a 6-pack, it's visible. And now Dilaudid is cheaper to get than beer, and it's easier to hide it.
Yeah.
It's easier to spread it because it's easier to hide it. So absolutely, it's become a recreational drug when it wasn't when I started this.
Yeah, and cocaine as well. They seem to be the 2 most popular, and both of them are lethal. You can overdose from cocaine. That's one of the primary substances for overdose.
If you look at Canada, the amount of people that have died of opioids, 54% of them also had crystal methamphetamine in their system. And I can't tell you the number for cocaine, but what I can say is that we've lost touch with what's really happening out there. And we've been very single focused. To me, I used to be a magician's assistant. And I feel like it's like a sleight of hands. look, we're doing something over here, as the tragedy is actually unfolding and we're really not getting a grip of what's happening.
That's exactly how I feel about it too. It's like we're all focused on the wrong thing. And yesterday, I addressed the all-party mental health and addictions committee here with the government, and that's what I said. We've swung the pendulum way over to the left, and we're trying to help and all these harm reduction and safe supply things. And you can be sure that that's going to swing back the other way based on the results that we're having worldwide and the number of people. But I think back, like in the 60s, you could drink in your office and smoke cigarettes in your office. And that changed with government changing the narrative around these things. And right now, our government is not responding to the narrative of addiction and the drug supply at all. It's almost like they're afraid of being singled out, as they don't want to admit they've done something wrong. Like, I think it's all in the world of looking good. It's like, look how compassionate we are. Look how good we are. Look how we're trying to help things. And at the same time, we're just having a mass slaughter of mostly young men in the age bracket of our youth. So at what point do we stop and say, wow, we really screwed that up? Or not even say that, just say, okay, this is killing our people. Anything with this side effect of death, like fentanyl, should not be allowed in our country. Someone's got to take a hard stand somewhere.
I think I'm just going to make another analogy, and many of your viewers are probably way too young to understand this analogy, but I'm going to make it anyway because it really impacts me. We can talk about something having a benefit, but that doesn't mean the harms are so good that any benefit we can see is something we have to recognize the harms are worse. And the thing I always think of is the thalidomide. If all we're focusing on is nausea in pregnancy, thalidomide is a good drug. All of the data would show that if you're, and nausea in pregnancy can be, people can get so sick they're dehydrated. It can be a risk for the mother and the baby to have nausea in pregnancy. It's not just uncomfortable, it's dangerous. Thalidomide works for that. All the data shows that. It's probably the best drug we've ever had. But the slight problem is that for the fetus, if you take it in the first trimester, you can have a lack of development of arms and legs. This is horrific. That doesn't mean it didn't get rid of nausea. It means that the side effect was worse than any benefit. So there can be some people that might be helped by this program, but the side effect far outweighs the benefit.
That is excellent analogy. Excellent analogy, for sure. And the people who are sitting there in the aftermath of this, all of these, like, to be able to get to a situation where all of our kids are dying, and to have the aftermath of 42,000 kids and their parents and families struggling with this, like, it's just insanity to me that we continue to do it. It doesn't make sense to me.
I think you're right, though. You sort of said once people do something, they have a difficult time admitting it's wrong. And to be honest, I experienced that. I supported this program at first. It took me a while to really, it took case after case after case of other types of infections. It took living in the community. It took seeing the encampments. It took seeing the youth. It took several years before I actually went public and said, no, the harms are worse than the benefits, because I had actually wanted it to work. But wanting it to work isn't good enough. Harm reduction means helping people decrease their risk. But once it means it's harmful for someone else, that's not harm reduction. If this program were witnessed, which I would still not help from a neurochemical level, and it still wouldn't be a best treatment. But if it was a witness program in a stabilized environment to get people to treatment, there might be a argument that it's a form of harm reduction. But when you're doing something that's harming so many of our youth, and you mentioned men, when I started my work 80% of my patients were women and 20% were men. Now, 80% are men and 20% are women, but the
Yeah.
numbers of women didn't go down. It's
Right.
that the numbers of men have
Sky,
absolutely escalated
yeah,
compared to when I started this work.
skyrocketed. I
Yeah.
have to commend you, Sharon, being a doctor who can, see the actual data and turn the ship around and head in the direction where you actually see and can admit, this is wrong. This is not helping our people. I think that's huge. I wish there was more people like you who could actually be authentic and tell the truth about this situation, because there's an awful lot of people that are being drawn into the safe supply thing, and they feel like, okay, well, I helped someone today, but they're not seeing, as you said, the big picture and how it's impacting all of the people, the communities, the safety of our communities. And not only that, like you said, in addiction, the brain is seeking that drug and it adapts, and then it needs more and more and more drugs. So if you're providing with someone with drugs, you're actually elevating the level of which they become accustomed to that drug, and therefore they have to seek more. So we're actually exacerbating the evolution of someone's addiction, and every time they do that, it hijacks the brain even more and makes it even a deeper and further addiction. The more you use drugs, the more it impacts your brain, the more brain damage it does, the more it stops that frontal cortex from making saving decisions. So these safe supplies are really responsible for continuing drug use and exacerbating it.
And absolutely. When you think about when people are able to get into recovery, first of all, it's a process.
Yeah.
But everyone who's told me has said it often is when there's an opportunity that they have time to think about it. We do what's called motivational interviewing, and we work with people to find their goals and to help look at pros and cons and work with people so that the pro of being on a drug is less than the con of being on that drug, and the pro of getting off is greater than the con of getting off.
Yeah.
But one of those things has often been things like availability and cost, and ability to use it. So if it's expensive, we don't use. When smoking's expensive, less people smoke. We have taxes on alcohol for that reason too. But when it's cheap and available, it's hard not to use it. It's there. It's so accessible that battle in your own brain of the work of recovery is a harder battle to make because you don't have to do anything to get the drug. But the other thing is relapse. Allowing it to be used everywhere is probably the cruelest thing we can do to people.
Yeah.
Because when you're doing well, people know to avoid bars and that can be difficult, but they know to. But when you're able to do something everywhere, it impacts you. I had a family member who had been in recovery and sober for several years, had a bit of a emotional event happen, saw someone using and relapsed. And we're forgetting the work it takes to get into recovery and forgetting the work it takes to stay in recovery. And we're losing that benefit when we're flooding the streets and making it the norm to use now, as opposed to really working with people to help them get into recovery.
Yeah, we have lots of comments flooding in here now from people saying it keeps the wheel circling in drug addiction. Harm reduction is enabling. It's wiping out our youth. And this episode is a must watch. We are nailing it. Well, that's good to know. Okay. So we have viewers comments here. I just thought I'd let you know that people are chiming in with the conversation. I mean, I think you're spot on, Sharon, and I'm so happy to see someone with as much experiences you do, working, in the trenches with it, being actually able to tell the truth about it. Because we have people wanting, getting so sick and wanting help, like going to, like here in Newfoundland, going to the Waterford, or our youth going to the Janeway. They ask 2 or 3 questions of that person who's severely sick, very, very, very sick. And they don't have capacity, but because they can answer the question, their name, they're not in deep psychosis, they can, basically answer a few key questions. Same thing happens with our judges here. They ask a few key questions and they say, okay, well, that person can answer them logically, therefore they have capacity. Nothing could be further than the truth. They don't have capacity. They just threatened to commit suicide. They just threatened to kill their mother and their grandmother. Like, these are actions of people who are so, so drugged and so, so sick. Like, sometimes taking 10 to 15 Dilaudids in a day. And as soon as they get their prescription, they take them all at once. Or they'll sell them for other stronger things. And the cycle continues until people get killed.
I also, when this started here in this area, I did see numbers like that, 12, 15 in a day. I can't remember the last time I saw a number that low. Most of the time when I see people come into hospital, their script is over 30 pills per day, often 40. But when we have them, and this is something that people forget, in hospital, we are supposed to put people back on their prescriptions. That's the World Health Organization actually had a policy on this. We're supposed to put people back on their drugs. If we did that, it would be fatal for most of the people I see, because when we actually see what they're tolerating, it's 10. One time we had somebody prescribed 40 who could only tolerate 2, enough that he'd be positive on a urine test. But had we given him 40 as a shot form, we would have killed him. And I see this, so the numbers, if you're seeing those numbers now, my warning is it's just going to get worse, because when all you have to do is come in and say, I want more, or if I don't get more, I'll use fentanyl, and the numbers keep going up and up. That's why the cost has gone down. I have estimated that from the amount of people that are on the program, in the program here in London, and I look at what they're prescribed, if I say 10, if half of them are diverting 10 pills a day, that's 1 million pills a year.
That's insane.
More of them are diverting closer to 30 pills a year, then it could be up to 6 million pills a year. I don't think it's likely that high, but I think 1 million is an easy estimate for the amount in this one area, based on not just a feeling. This is based on what I'm seeing for what people can tolerate when it's witnessed, but it also puts them at risk. When you get an infection, you don't tolerate as much opioid as you do when you're healthy, when you have a pneumonia or a heart valve infection. So it's not a safe supply. It's a dangerous drug that is escalating and escalating and escalating. And I just don't know how much suffering we have to witness before we can say, yeah, we need to go back and do this right and really help people without hurting them.
Yeah, because inadvertently we live in a society that is perpetuating substance abuse cycles, and it's worsening by the minute across the country. And what I hear in the words of our politicians is, well, it's happening everywhere. We can't help it. There's going to be drugs, here and there. And I'm like, we are the people. We are architecting the future. We are here to create a future for our kids that is actually going to be sustainable. And that means some hard and fast rules about what we're putting into society. Like, we created it, we can fix it. And not only can we fix it, I love the fact that certain people are out there creating what they call inclusive recovery cities. They're creating a culture, a conversation, a society that, first of all, builds community, which you need in recovery. You need to feel like you fit in. You need to feel like because you have that illness, you're not excluded to the streets, and all these infrastructures and programs around it, 12-step and everything else. I love the idea of sober, inclusive communities, sober, inclusive villages, sober, inclusive cafes, inclusive recovery, towns. That to me is being smart as a government and as a municipality with designing a future that everybody's going to want to come to. Because if you have a town or a city that it's just drug laden, everybody's going to move out. It's going to ruin the tourism. And the cost of not fixing it far, far, far outweighs the cost of that you're going to invest in fixing it up front. It was like I said to the government yesterday, it's like paying your taxes. You don't really want to do it, but doing it means that you don't incur penalties and interest. Well, in this case, I have more than just doing our taxes. I want to be the finance company. I want to have recovery resorts. I want to have sober living homes where people love to go to, want to go to, have a culture of peak performance, productivity, self-awareness, contribution, and let's reframe the whole thing.
I think those are absolutely beautiful ideals and wonderful place where we need to be looking, where we need to be focusing for our future, and having it a safe place for people to get into recovery and stay there. Having said that, I also think we have to recognize in the immediate term, we need to absolutely enhance our ability for people to get into treatment. In London, for example, where we have this, our rapid access addiction medical clinic, where we can get access to opioid agonist therapy and treatment, counseling, is only open 2 days a week and 2 half days a week. And even in those hours, I don't think it's ever open beyond 4 o'clock in the afternoon. It's not meeting the needs of people. We do not have, and the only program that is associated with primary care is the Safer Supply program. So if you're in an opioid agonist, if you're getting Sublocade or Suboxone, it's separate from being able to have access to primary care. So when I look at the benefits that people do save from the program, I can say that the vast majority of those benefits can be completely attributed to being in a program. Just being able to be in a program helps. Being in a program where you're treated respectfully helps. But to have access to primary care, we're giving out allotted all over the country, but we don't have access to primary care in many of our neighborhoods and a lot of our provinces. That needs to be a focus, and access to preventative care, and then access to treatment facilities. All of these things need to be covered too. They need to be supported by our government, and they're not. That's where the sleight of hands. Look what we're doing over here when we're not investing in treatment and facilities that we know are proven and safe and don't harm other people.
Yeah, you're absolutely right. And it's a two-prong approach. Like we advocate for our families, mostly people from Newfoundland. And one group member that I helped, her brother was in Alberta. And much to my surprise, I found out about their 24/7 program. So the minute that someone presents with any kind of mental health or addiction issue, right off the bat, as soon as you go through the doors, you are seen by someone who will determine whether or not you have mental illness, an addiction, or both. And all three require different protocols of care. And that person is surrounded right from the get-go in a 24/7 service that deals with that right up front. That's what we need across Canada. Alberta's definitely doing a lot of leading edge stuff that I think is right. And it's driven by input from people who are in recovery, so they actually know the system out. And the people that are going to get us out of this are the ones who are in recovery, because they've lived it. They know what to do. They know what's needed. They know all the loopholes. They know how to they've gone through the manipulation of the system. They know how to get the drugs. The other piece is doctors who are continuing to prescribe. My son Ben was prescribed, highly addictive sleeping pills when he had a long track record of addiction. He never had sleeping issues. Doctor didn't listen to me. And every time I went to try and figure out how to get that doctor to be accountable, I either had to report him so he lost his job, which I don't think is effective, or I also had to put up with it because they all have insurance. And so there's nothing you can do. So how can we hold doctors accountable for not putting all of these drugs into the marketplace, and hold our government accountable for, I think it was $600 million we spent on hydromorphone in BC? Like, that's astounding numbers. That's enormous amount of taxpayers' money. How do we stop that?
I think that's a really important and good question. And I look at, the Safe Supply program in London has received over $8 million of funding. And it states that it's helping 300 people. I also work in a community south of London, St. Thomas, where they have had no funding, and they have 175 people on a treatment program that includes injectable Sublocade, and have better results with no funding. So I don't think we're getting a good accountability in any way of what we're doing with our funding dollars. But what it's doing is fueling this. Actually, as I'm thinking about this, the government will talk about how the research is showing benefit from the program, but the only research they've funded are the programs themselves. So when you're getting $6 million or $8 million, part of that can go to research which, as I can say from a methodology perspective, is questionable. But what I can say is that the only funding for research is just among the people in the Safe Supply program. So it's like giving a pharmaceutical company money to prove their drug works and not listen to anyone else who says, but it has a problem too. And that's all we're doing.
That's so unethical, so immoral. And like, where is our good governance in the country that is taking account of that? And where is our media in all of this? Where is CBC in all of this? Like, CBC should be on top of this like a dog with a bone. Because it's actually now bigger than COVID-19, in the sense that the number of people who have died within the regions, and we are treating it like it's not even here. That is a communications breakdown at a fatal level, at especially CBC, that's funded by the public, should be doing their job on that and disclosing all of those loopholes and all of those reasons why these things are happening. I mean, I'm just a citizen who doesn't get paid, who creates a podcast to get this information out because my son died. And so many other parents have kids on death's door. So I'm doing what I can to help. But if I had the infrastructure like CBC behind me, we could turn this thing around.
I agree with you. And I like when you're talking about people who volunteer, all of the work I've done to speak out essentially is volunteer work. I don't get paid for any of this ever. I'm not paid, where people in the program that are on salary can be speaking out and they're paid for what they're doing. I am not receiving anything for anything I'm doing. I'm speaking out as a physician, as someone who lived in the neighborhood, and as a mother. And as I mentioned before, I had a child who was in a community 2.5 hours away from me who was blatantly psychotic. And they cleared him and released him and didn't even allow me, a physician, the opportunity to go 2.5 hour drive, jump in my car. They wouldn't even keep him hospitalized for me to get there. So I know what that feels like. I know what it feels like to have family members who are now sober relapse because of what they're seeing. I do think I'm lucky that Safer Supply was not available when my children were younger. My children are now older. My youngest one is over 30. If this had been around when they were in high school, I do not know if I think I'd be at risk for not having all of my children. And
That's such an important message, but because I don't think people realize the extent of the danger we're in. And yesterday I posed the question, if your child went out into a pond and started swimming and got into trouble and they were drowning, what would you do to save that kid? Well, you do anything. And, of course, people came up with all kinds of suggestions and everything. But the reality is our kids are drowning right now. Our kids are drowning. Our teenagers are drowning. They're dropping out of school at unprecedented rates. They're taking more drugs than ever. The drugs are more lethal and deadly. More kids are dying. It's the number one cause of death in our youth. Why is that not on the top of every headline of every freaking newspaper across this country until it stops? I don't understand. And so we've normalized it. And so that's on us. That's on us. That narrative, being allowed to continue and normalize it, like drowning kids are dying, that has to stop.
I loved that analogy because that's actually one I use. So when we're talking about safer supply helping people, because there's sort of this thought that if it was out there, that we would decrease overdose deaths from fentanyl. We won't. Fentanyl will be there, and it will continue to be there, and it will not be impacted in any positive way by adding more hydromorphone to the street, more Dilaudid to the street. But even if we think about the people, that they think they're saving, my analogy is it's like you do have these drowning people, and you send a life raft for 2, but you're throwing in 3 more people. So if you look at the data from London, because of how much higher we are than the provincial average, for any 2 that are helped, 3 are hurt. That doesn't make it work. So when I know I hear the cries of people who've had children who've died of fentanyl and thought that if Dilaudid had been available for them, that they might not have died. I think that I hear that pain, I do. But the reality is they're much more likely to have gotten into this because of Dilaudid, that they likely started with Dilaudid. Very few people I see using fentanyl started with fentanyl. They start with Dilaudid. And that's what gets them there.
Exactly. There's a mass of drugs that are out there. My son Ben died with 7 different drugs in his body, and he wasn't one of a kind. The coroner told me that is commonplace with most of the people who are overdosing. They just have a raft of medications. Their brains are obliterated. They have no capacity whatsoever to make a life-changing decision. And they're getting pills from all over the place. So we've saturated the market with prescription drugs, and we've saturated the market with street drugs. And our judicial system has allowed it to happen. Our prime minister has allowed it to happen. Our ministers at each provincial level and municipalities have allowed it to happen. And we have got to step up and stop it. It's insane.
I agree. 100%.
Well, we've been here chatting for almost an hour, so I just want, is there anything else that you would like to say?
I guess I first want to say thank you to you for what you're doing. I'm so sorry for what you've been through, and I'm so
thanks.
Amazed by your courage, and I'm feeling a sense of relief from your courage, that I know as someone speaking out that it's can be very hard to. It can be easy to, every now and then I think I'm tired of the difficulty it's been to speak out, and the bullying, or being told that I'm not really seeing the suffering that I'm seeing. But then I go see my kids, and they tell me I need to do this. And I just, they're not the only ones. I see the nurses that I work with, the other people who are in allied health, the people in the hospital that actually see this and see what I'm seeing and are working with me, that are so supportive. The people in the neighboring community that have a much better rate, that they can't get the voice, that nobody's listening to, that are doing it right. And so thank you for the work you're doing and for getting the message out.
Thank you so much. I mean, I've had backlash as well from safe supply people who have taken, pot shots, character, smashing, bashing, all the rest of it. But at the end of the day, I think taking the large vantage point and being able to see the big picture, and being able to understand what's possible for our country is the only way out of this. And I hope we do it sooner than later, because every single day we're trying to help parents and family members save their kids. And it just seems like such an uphill battle. We're fighting and fighting at every turn just to get one person into recovery. And thankfully, since Ben died, we have 35 people gone to recovery, and that's a win. We also have established the first recovery magazine in Canada, I believe, certainly for our province. And that actually comes out this week. And it's an interactive magazine. So you can click on a page and it'll go interactive to this podcast, for example. So we're using technology, we're using communications mechanisms to get the word out, and using social media, because those are the tools that we have. I could only imagine what we could do if we had, a lot of investment into recovery, sober living homes. All roads lead to recovery. So I think people need to band together. Our government needs to band together, and our voices need to band together to make this right and make it happen. So thanks once again, Sharon. Love the work you're doing. Love to have, if you have new developments, let us know. We'll have you back on the show.
Great. Thank you so much.
Anything that you want to focus on in particular, we would love to have you. And to our listeners out there, join us in our continued exploration of the solutions of the illicit drug crisis. Here's to hope and healing. And until next time, I'm your host, Tina Olivero. Over and out, everybody. We'll talk to you on the next podcast, which will be sooner than later, I guess. We have them every couple of days these days. So ciao for now.
Bye-bye.